this part of the course, we will be talking about some of the parasites that they infect the gastrointestinal tract. And, and in this part, we will be talking about protozoa, that means the unicellular organisms, and metazoa. We will be talking about some of the worms that they infest the gastrointestinal tract. We will be talking about their structure and then their multiplication, and then some of the cardinal feature signs for identification, the diseases that are associated with, and then how to make the diagnosis, and then, of course, treatment, and finally, we'll talk about prevention. Those are the parasites that infects and infest the gastrointestinal tract. We will not be talking about all of them. We will concentrate about some of the most common ones. As we said, we'll talk about the rhizopoda or the amoebas, Amoeba histolytica, for example, and then we will be talking about Giardia Lambia as well, and then some others that are common in our part of the world. So again, then we will start with the protozoa that they are going to infect the gastrointestinal tract, and then we will be talking about the worms from different classes and subclasses that are going also to infect the gastrointestinal tract, and the diseases that are going to be associated with those in general. So the first protozoa, then Amoeba histolytica, which is one of the most common and the most devastating protozoa that you are going to study. And this one can be present in the trophozoite form or the cyst form through the fecal oral contamination. It is present all over the world and can be associated with intestinal manifestations or extra-intestinal manifestations as well. So we will be talking in details about Amoeba histolytica and the most common complications that could be associated with. So Amoeba histolytica belongs to a group of protozoa. Here we call them the rhizopoda or the amoebas. That means those they don't have a fixed shape, but they can be present in two forms. The first form, here we call it the trophozoite form. It's about 10 to 30 micrometers in diameter, and you can see a nucleus, and those can be identified by the nucleus that they are having here, and usually they can have up to 4 nuclei, but the trophozoite is usually having 1, and the nucleus is about 5 micrometers in diameter, and they do have a granules. We call them the chromatin material, and the chromatin is usually present in the periphery of the nucleus, and it's homogeneous. That means it is just solid-like structure. One nucleolus usually is present, but it can be more than one in the cyst stage. So in the trophozoite, then this is the infectious stage that is present in the colon, and just when doing the stool analysis in an acute type of infection, you can see that and easily can be identified in patients with an acute type of an infection. Within the cytoplasm, we could see here some red blood cells that they come from invasion here property, and so here Interneta histolytica is associated with an amoebic dysentery. So the dysentery, we mean by that mucosal destruction, lots of red blood cells, white blood cells that could be phagocytosed by the amoebas. Very important to remember that. And this organism produce enzymes. We call them zymodemes, that we use them for identification and for classification of the amoebas in general. Remember that Interneta histolytica can be associated with infection to the colon. We call it intestinal amoebiasis or amoebic dysentery, and also can be associated with an extra-intestinal, outside the intestine, and the most common site outside the intestine is the liver. So they can be associated with what we call an amoebic liver abscess. Amoebic liver abscess. And as I said, that those can be identified and classified by the enzymes that they produce. We call them the zymodemes. Very important to remember that. So you could see more than one trophozoite, but usually we could see one cyst stage, and you can see in some more than one cyst stage. Also that also you can see the nucleus, and also sometimes you could see glycogen granules that's present inside. So we'll talk in more details about Interneta histolytica, the causative agent of amoebic dysentery, and we said that it could be associated with an acute or chronic type of diarrheas in general, and some of those look like Interneta histolytica, that they could be non-pathogenic amoebas. They look like Interneta histolytica, which is really pathogenic. And the most common virulent factor beside the enzymes that are associated with the tissue lysis is the lectins that the organism uses for attachment. Lectins like cysteine, and the proteases also that are associated with destruction to cell. And by analyzing the enzymes that they produce, what we call the zymodemes, we can identify or classify here those amoebas for epidemiological purposes. it is associated with ulcerative inflammatory here lesions that has to be differentiated from other ulcerative inflammatory lesions that they could affect the colon, like ulcerative colitis and many others. And remember, very important here, the extraintestinal manifestation or sites, and mainly it is the liver, but they could go into other places like the heart, for example. Then again, talking about Interneta histolytica, belongs to a group of protozoa. We call them the rhizopoda, means the ones that have pseudopoda or not real here projections or foot, just not true feet projections. And here we can classify them based on the enzymes that they produce here and damage the cells. Some of these enzymes, like the glucose phosphate isomerase and phosphoglucomutase, for example, and the oxidoreductases, هذا اللي سميناهم zymodines that we use for identification purposes and classification. وحكينا إنه size is around 10 to 60 micrometers in diameter, and we can identify them by here the shape of the nucleus, the cytoplasm as well, and we said that the chromatin bodies also that they produce, and the glycogen also bars that are present in general. This is the life cycle of Interneta histolytica, which is simply alternating between the trophozoite form and the cyst stage. The cyst stage is the infectious stage that goes outside, contaminating water and food, just material. And so if we ingest them by the water or the food, then they will go into the intestine, and over there they will exist, and each nucleus they will circularize and form an amoeba and causing intestinal ulcers. This is the invasive type, causing invasive type of a diarrhea, and some they will go outside the intestine and going into the liver in particular and causing an abscess, amoebic liver abscess, we call that. Yeah, and this is the same slide almost showing the same concept, whether Interneta histolytica is associated with intestinal amoebiasis, ulcerations, for example, or dysentery, we call it. And here the patient is going to be associated here with not just diarrheas or intermittent diarrheas, but a bloody type of a diarrhea that is, when you analyze it, you can see fecal leukocytes and red blood cells as well at the same time, and they could go as well extra-intestinal into the liver associated with what we call amoebic liver abscess. So when we talk about Interneta histolytica, we talk about the cyst stage and we talk about the trophozoite stage and how to identify those. وحكينا إنه usually you need around minimum of 100 cysts to start an infection, but in the literature they found out that one cyst is enough to cause infection, which is extremely important to know. حكينا عن الintestinal manifestations and the extra intestinal manifestations or the amoebic liver abscess. Patients, they could be symptomatic, means intermittent diarrheas and the amoebic dysentery. Here, very, very important to remember that. Or patients, they could be asymptomatic and they could keep just secreting those cysts, and then if they contaminate water and food, they could be here associated with that. Very important point to remember about what we call the cultural habits. Certain population where they consider washing fruits and vegetables and just general cleanliness as part of like being a soft type of behavior, and if they want to be tough, then they eat the fruits and vegetables without washing them. So it depends on the cultural habits and how they look into the concept of cleanliness is extremely important to know. So remember that, and remember that asymptomatic state is so important that they could also be responsible for contaminating the water and food that we are eating. It's not just that, but homosexuals as well could transmit that from one patient into another, and those homosexuals can be responsible for the transmission of these cysts from one patient into the other. So fecal oral route is the most common here mode of transmission of the amoebic, the amoebas, or the intestinal amoebas and the extra intestinal amoebas. So again, get back to Interneta histolytica, and their effect on our body is usually because of the enzymes that they produce as associated with what we call a lytic effect on tissues in general. And this is the most common problem that we could be seeing. Sometimes we could have what we call an amorphous granules. Well, geographically, they could be distributed in many parts of the world, but also they can be associated with just histologically, just tissues distributions in many geographical areas all over the world, but the most common areas where those are present are the areas with low socioeconomical status, poor conditions that are not associated with healthy, just general cleanliness type of measures, especially washing fruits and vegetables before eating them. This is extremely important to know. Very important also to know that the colonic environment and the rest of the normal flora that is present in the environment plays a major role in protection against the Interneta histolytica trophozoites. After all, the effect then is going to be liver, for example, necrotic abscesses as well. This is very, very important on the extra-intestinal side. And they could be associated with perforated fibrosis to the intestine. They adhere to the intestinal mucosa and sometimes could lead to perforation as well. And yeah, as I said, the protection role effect of the normal flora is extremely important in those patients. And some patients, they could be resistant more than others to be infected with Interneta histolytica. Some people, they do have more damaging effect compared to others, and some they could have here an effector mechanism like the C5b up to C9 role of the complement could be affected with Interneta histolytica. So the protective immunity against Interneta histolytica, we can see that certain patients are more susceptible of being infected compared to others, and some patients, they could have more recurrence and compared to others as well. Some, they will develop more antibodies compared to others. So it's very important here to know that not all people, they are infected with Interneta histolytica the same. So some people, they could be asymptomatic, might not show any signs and symptoms, while others, they could have a serious type of a disease. And some, they could develop complement resistance compared to others. And some, they produce secretory IgA antibody and cell-mediated immunity, while others, they might not. So here, for example, patients that are on corticosteroids, you know, corticosteroids, they suppress the immune system, and cell-mediated immunity in particular will be compromised. So those, they could be more susceptible of being infected with Interneta histolytica compared to others. So could we really make a vaccine against Interneta histolytica? Can you think of a way here to enhance immune response against Interneta histolytica? So they have tried here with the lectins that are present with Interneta histolytica, but till now they don't have a very effective solid vaccine against of Interneta histolytica. But the mucin that is present in our stomach, it looks like it has a more protective role of being infected with Interneta histolytica, because it seems that mucin will interfere with the adherence of the lectins of Interneta histolytica compared to others. So we said that Interneta histolytica could really cause a severe invasion to the gastrointestinal tract, or they could go extra-intestinal into the liver, causing amoebic liver abscess. This is extremely important to know, and some they could be asymptomatic as well. So the scope of infection from severe invasion, destruction to tissues, into asymptomatic, for example, and they carry these cysts, these infectious stages from one patient into the other. cyst stages in particular. And this is a case study, and those case studies are so important to understand the scenario of an infection. And talks here about a patient who was in a mission in South America, and how he developed amoebic amoebiasis in the gastrointestinal tract, and then how he developed an amoebic liver abscess. And the way they have diagnosed the amoebic liver abscess is just simply from the history of the patient, and second, by doing an ultrasound into the right side of the body where the liver is, and they found out that there is an amoebic liver abscess to be considered in this patient. So then, as we have seen, that the clinical presentation of amoebiasis could be just clinically evident, and they could be asymptomatic, whether it is an invasive type of a diarrhea, or sometimes might not be invasive. It means that it doesn't show. It could be asymptomatic, and usually the liver is enlarged in those patients. But some might not have hepatomegaly as well, but in general, the invasion of the liver will be associated with a high fever. Not all patients they are going to have fever, but many of those they could be associated with fever. So fever indicates tissue injury, and if diagnosed here with the ultrasound, that confirms the liver abscess. But some they could have here some what we call toxic megacolon. That means the colon could be enlarged and could be paralyzed, and hemocal is always positive in those types of patients to make the diagnosis of an amoebic liver abscess, or destruction to the mucosal lining of the intestine. So this if you if the patient is having a massive here ulceration of the colon, as you can see, it could be ended with the removal of the colon. We call it hemicolectomy, and the colon could be removed out and sent to the lab. You could see the dysentery-like symptoms that in the mucosal lining of the colon showing the massive injury to the colon. And here, this slide will show just simply when you do the stool analysis, the cyst stages of the Entamoeba histolytica. You can see the nucleus, and here the fine distribution of the cytoplasm of the cyst stage. You could see more than one nucleus, but in this slide you can see just one nucleus and the evenly distributed cytoplasm in the cyst stage. So you could see that also, which confirms the diagnosis of amoebiasis in general. So the diagnosis of an amoebic liver abscess is usually by an imaging techniques, and you can see from the images or X-ray guidance, you could see the amoebic liver abscess, and through that you could go into the abscess, aspirate, and you could see the trophozoite even in the abscess. And if the patient is having uh, just an infection to the colon, uh, just you can do the stool analysis and you could see also the trophozoites or the cyst stages in the stool. And you should here think of other associated illnesses or what we call differential diagnosis, and what could be other than the amoebic liver abscess or the colitis associated with the Intestinal histolytica. In the differential diagnosis, just we have to think of anything that causes severe inflammation to the colon, and maybe Crohn's disease, ulcerative colitis. Those are the two main common diseases. Those are autoimmune diseases that could be associated with a very similar manifestation of amoebic colitis. Very important to remember that. So the imaging technique then is the technique that has to be taken in consideration to make the diagnosis, and through X-ray guidance then you can go into the liver and aspirate and see the trophozoites of Intestinal histologically from the histology. Also, we could be doing serology and see an antibody level against the Intestinal histolytica antigen. But the aspiration of the liver abscess, as I said, is the treatment of choice under, of course, X-ray guidance. Aspirate the abscess, and treatment of an abscess is just always to evacuate the abscess, and there is no other way here to treat the abscess other than the evacuation. So the evacuation here or is the treatment of choice for the amoebic liver abscess by surgery. So sometimes when you take a biopsy or evacuation and a liver abscess, you have to look carefully, and you could see the amoebas, and usually it has to be more organized and diffuse to make the diagnosis. But sometimes you might not be able to see that as a classical textbook, as you can see. But a patient with an abscess, and you can see those here cysts, it is an amoebic liver abscess until proved otherwise, and you can confirm that with serology as well, as we said. Other pictures also showing these cysts from the liver to make the diagnosis, and you can see the nuclei that are evenly distributed. Here, fine cytoplasm in both. This is the classical finding of an amoebic liver abscess. When you look into a slide like that and see a cyst stage that do have more than 4 nuclei, then by definition it's not Intestinal histolytica. If 1, 2, 3, 4, 5, then by default this is not Intestinal histolytica. Very important point to remember. The cyst has to be up to 4 nuclei, no more than that. More than 4, it's not histolytica. So it's extremely important to differentiate Interamoeba histolytica from the other amoebas, as I said, that are not associated with disease. So histolytica is the only virulent one. Maybe the one that looks like Interamoeba histolytica is Interamoeba dispar, we call it. That is much smaller than Interamoeba histolytica. The others, they are much larger. Uh, uh, so if you look into this one, this is Interamoeba histolytica, for example, and this is also Interamoeba histolytica. Uh, Interamoeba dispar will look like this one exactly, just a similar, smaller image of Interamoeba histolytica. While, for example, here Interamoeba coli, you can see a large nucleolus and irregular chromatin. Irregular chromatin, this is characteristic of Interamoeba coli, which is non-pathogenic. Other one, also from the non-pathogenic commensals, like Endolimax nana, same thing here, and you can identify them by here clear chromatin bars. You have no chromatin on the periphery of the nuclear membrane, for example here. Dientamoeba fragilis, you can see more than one nuclei that are fragmented, but no chromatin material here. This is very important for the identification. And we have one that produces a glycogen here, vacuole. We call it the iodamoeba botulinii. So when you stain it with iodine, it will look blue or dark in color here. So all of those are non-pathogenic. Remember, the only pathogenic one is Interamoeba histolytica that will have evenly distributed chromatin, one karyosome or nucleolus that is central. This is very important to remember. Don't ever forget that. While the others, they are non-pathogenic and just you need to identify them or to differentiate them from Interamoeba histolytica. So here you can see some of the differences between Interamoeba histolytica and the other commensals microscopically. Here regarding, for example, just some of the differential parts here to Interamoeba histolytica and others like dispar or the others. You can see in relation to the differentiation of the chromatin material. For example, the number of nucleoli, for example, here up to 8, you can see, while Interamoeba histolytica up to 4, no more than that. Sometimes the size Interamoeba coli can be up to 12 micrometers. Here histolytica up to 12, usually less than 12, no more than that. And like the others that we talked about regarding the chromatin material that is evenly distributed around the nuclear membrane rather than the Interamoeba coli, for example, they are not. Uh, here, it's so important to differentiate on the number of nuclei as well in histolytica up to 4, while others can be up to 8, for example, like the Interamoeba coli, for example, and so on. then the treatment of choice then is to use the specific anti here Intaniba treatment. Maybe the drug of choice that you should remember is metronidazole. Metronidazole. But sometimes we could be using other medications, as you are going to see. So some of the problems regarding the treatment that some will ask if a patient discovered that he carries Intaniba histolytica cyst and he or she is asymptomatic. Do we treat? The answer to that is yes, because he could be infectious to others. And this patient has to be followed up regularly till he or she is clear of infection. Sometimes we use the antigen or antibody detection in order to differentiate between Intaniba histolytica and the one that looks like it, which is the Intaniba dispar. So by serology, we could identify both of those, whether histolytica or dispar, because it's so important here to differentiate. One is pathogenic and one is non-pathogenic. Stool analysis, here we follow up the treatment. So by stool analysis simply, we could see if the cyst is present or not, and if there is no cyst, then the patient is clear. If we could use other medications like diloxanide, if you rate for example, uh, uh, but always we said that the drug of choice that we use is metronidazole. We could use the paromomycin also, and we could use tetracycline to get rid of the bacteria that the parasite could be using as food. Uh, so, but remember that metronidazole or flagyl is still the drug of choice that we use for the treatment of amibiasis. We have even a new modified a drug that has the same mechanism of flagyl, which is the tinidazole. Also, we could use that also for treatment. Another one called the hydroimidine also could be used for treatment. What's the treatment of an amoebic liver abscess caused by Intaniba histolytica? As we said, surgery and evacuation of the abscess. Always the treatment of an abscess is evacuation and drainage. Treatment of abscess is always evacuation. Remember that. It's the only way to treat an abscess. Okay, so if we need to talk about prevention of amoebiasis in general, it's extremely too important that the mode of transmission is through contaminated water or food. So water and food fecal contamination is the key here for treatment of Intaniba histolytica. So we have to be very cautious about that. Uh, the most common food that is usually responsible for the plasma is usually the fruits and vegetables that we eat raw and we don't cook. If we do not wash them properly, then we could be infected. So for extra caution, then we have to use a strong detergent soap and to wash the fruits and vegetables before we eating them, especially in rural areas, القرى and so on, where you could have those protozoa present, or you could use an acid like, for example, uh, الخل, for example, acetic acid here is so important here as a detergent to kill those protozoa. Some vegetables, if we boil them for a short period of time, we could kill or inactivate those. Only boiling of water, for example, you want to drink the water, is very effective. So you can boil the water and then cool it down before drinking it is an important protective measure. What about the waste disposal, where they could have those protozoa? Then they should be here important how to dispose the material that is contaminated. Very important. And of course, the ones that have certain sexual practice, especially homosexuals and oral genital sex, could be responsible for the transmission of those protozoa. So those guys have to be educated about the modes of transmission. Fecal, oral route is the rule in those cases. The second protozoa that is associated with diarrhea, but here is a non-invasive type of a diarrhea, is called Giardia Intestinalis or Giardia Lambia. So the difference between Internida histolytica and the Giardia, that Internida histolytica is associated with an invasive type of a diarrhea. That means you have red blood cells in mucus and bleeding in the Internida histolytica, while here with Giardia Lambia, it is non-invasive, severe watery type of a diarrhea. So the difference is extremely important for you to know. Giardia Lambia or Giardia Intestinalis affecting more children than adults, because children usually they are uncontrolled and they easily have access into food and water that is contaminated with the Giardia Lambia cyst. So this is extremely important to know. And the other difference here that the Internida histolytica usually affects the large colon, while the Giardia Lambia or Giardia Intestinalis, it is the small intestine and interferes with the absorption, of course. So you can see a greasy type of a diarrheal fluid. And this is so important to differentiate between Internida histolytica and Giardia Lambia. Giardia Lambia, because of the greasy stool, it has a foul type of a diarrhea, foul smelling and رائحة كريهة, compared to that of the Internida histolytica. So very important to know these differences. Most important to remember invasive versus non-invasive type of a diarrhea. So the same thing here applies for Giardia Lambia, that we do have a trophozoite stage, and we have a cyst stage. The cyst stage is the infectious stage, while the trophozoite stage is the disease-causing stage. And as you can see here, it belongs to a different class of protozoa. This is a flagellate, as you can see. So the trophozoite has a flagella that here is responsible for the repulsive type of motility compared to the amoebas. Well, the amoebas, they don't have flagella at all. They have pseudopoda, while here the Giardia, as you can see, have here 4 pairs of flagella that they can keep moving compared to the Entamoeba. And the Entamoeba, of course, is invasive, while this one is non-invasive. So again, this is a major difference between the invasive type of diarrhea caused by Entamoeba histolytica and the non-invasive type of diarrhea that is associated with Giardia Lambia or Giardia Intestinalis. This is a protozoa, small, around 15 micrometers in length by around 9 micrometers in diameter. You have 2 sucking discs that the Giardia uses it for attachment, and it's mainly in the small intestine. So once in the small intestine, usually it is associated with what we call malabsorption. So you can see a greasy type of diarrhea associated with this type of an infection, and malabsorption, of course, because this is in the small intestine. So among the flagellates that we are going to study, maybe the Giardia Lambia is the only flagellate that infects the gastrointestinal tract, while the others that they will look like here Giardia, or they are flagellates, they are commensals, not associated with infection. There is one that is infesting or infecting here the sexual organs, especially in women, which is the Trichomonas vaginalis. It is associated with vaginal discharge. Very, very important, has nothing to do with the gastrointestinal tract, but it's among the flagellates that are associated with infection to humans. So remember that Giardia Lambia here causes infection to the intestine, and Trichomonas vaginalis causes infection to the vagina in ladies. The common feature between those that they have flagella, or they are flagellates. The first one, Giardia Lambia, the small intestine, and Trichomonas vaginalis is in the vagina, as you can see. So those differences are extremely important to know. The others, they are commensals and not associated with a disease, but you need to differentiate them from the Giardia Lambia or the Trichomonas vaginalis. So Giardia Lambia, then again, is an intestinal flagellate that's associated with severe watery diarrhea and malabsorption. Very important to know. It is a flagellated here enteric protozoa. Very important to know that. It could be endemic in certain areas, and it's always there, or could be associated with an epidemic infections, and usually the same thing through contaminated water. So contamination of water is the main cause of infection to Giardia Lambia. Many names for Giardia Lambia, common ones, Giardia Intestinalis, or Giardia Duodenalis. So all of these names can be used, Duodenalis, Intestinalis, or Lambia. The most common nomenclature or naming is Giardia Lambia. Very important to know. It is, and you could see many antigenic variants of Giardia Lambia um, that they have or they share the same manifestations of severe watery diarrhea. And you can culture this organism here as a protozoa, and we could culture it in the presence of biliary lipids. So you add the biliary lipid salts here to, then you can culture it in the lab to make more antigens that you could use, for example, for vaccines or for laboratory use. So many of those protozoa can be cultured in the lab, including even Entomida histolytica, to make antigens that sometimes you could use for vaccines. And the same thing for Giardia Lambia, and we use biliary salt here in order to make a media for culture of these protozoa. So this is actual photos of the Giardia Lambia, the cyst on the trophozoite. You can see usually it has two nuclei, and around the nucleus you have the sucking disc that it uses for attachment, as you can see around the nuclei, and have four pairs of flagella distributed all over that the protozoa uses for propelling type of a movement. So if you see it once, you will never forget it, especially in the trophozoite stage. You can see the two nuclei, maybe not that you can see the flagella. Sometimes it's so difficult unless you use special stain for the flagella. But you can see the two nuclei and the sucking disc around those. When you look at it, you will see as if somebody is looking back at you. This is characteristic for the Giardia Lambia. Other photos showing the Giardia Lambia, sometimes you don't see them classically as in the first slide. But if you look carefully, you can see the nuclei and the sucking disc around them. When you look at them as if somebody is looking back at you, and when you see them once, you will never forget them. Giardia Lambia or Giardia Intestinalis or Duodenalis, 15 micrometers in length by around 9 micrometers in diameter. More photos showing the trophozoite stage of Giardia Lambia or the Giardia Intestinalis or Duodenalis. Same shape. You can see the two nuclei and the sucking disc around them. Yeah, this is an electron microscopy or electron micrograph of a stool specimen from a patient who has severe watery diarrhea. And you can see the Giardia Lambia here, trophozoites in the stool specimen. You can see the sucking disc here. This is pathognomonic when you see that it's Giardia Lambia until proved otherwise. And sometimes you could see those even moving in a propelling type of a movement from a fresh diarrheal fluid. It's pathognomonic. So the shape of Giardia Lambia should never be forgotten. It's like a whiskey monkey face protozoa. So again, this is another micrograph showing the Giardia Lambia, the small intestine. You can see the microvilli or the absorptive surface of the small intestine, and you can see the Giardia Lambia or the Giardia Intestinalis around here. So their pictures, they are so pathognomonic. So again, this is just a clinical capsule just explaining a patient who is infected with Giardia Lamblia. That the patient is going to have a severe watery type of a diarrhea, vomiting, uh, just abdominal pain and cramping here of those patients. So severe watery diarrhea, no fever in most of those patients because there is no damage to the intestine. Severe watery type of a diarrhea and malabsorption. Okay, then I will stop here about for part one of the protozoa that is associated with diarrhea, the histolytica, Giardia Lambia, and then we will be talking next time about the rest of the parasites that are associated with diarrhea and infection to the gastrointestinal tract.